talk now is about the strabismus reoperation. And as you know that the reoperation sometimes is making conflict with the patient as second or third time. He's so worried about that. So how to avoid to do the third time of surgery for these patients? The consecutive horizontal strabismus could be after surgery for the esotropia or for the exotropia. We have to see these cases clinically first. Case 1, 9 years old school girl with history of previous subsequent surgery. Most of the patients will come without any report of the previous surgery, especially for the consecutive exotropia. We cannot find that what much of surgery, how many surgeries are done, sometimes one, sometimes two. What is done, is it BMR, recession, how much is done? And so we have to depend on our experience clinically or by imaging. So this case, there is no report, no detailed history. She has exotropia, usually increasing gradually. She's fixating with the left eye, and her angle of exotropia in the right eye is different than the left eye. The right gaze is different than the left gaze. And there is limited deduction, OU, but more in the right eye. For the case number 2, is a 40 years old male. He has history of right paranasal sinus surgery. And this is done by a famous ENT surgeon. He has XT increasing gradually, and his visual acuity is 20/20 in both eyes, and he also has incompetency. The angle at the right gaze is different than the angle in the left gaze. So he has severe limited deduction in the right eye. So what to do for these two cases? They are too different. What is the management? What is the approach? Are we going to do clinically only, or we need imaging for these patients? So clinically, we will depend on the orthooptical evaluation. If the exotropia is unilateral or bilateral, angle measurement, more at near or at distance is very important. If there is any convergence insufficiency, exotropia, is there limited deduction in one or both eyes, and the exotropic angle in more in direction of the action of one muscle or two muscles. So for the medial rectus of one muscle of one eye, or the both medial recti in both eyes. So by slit lamp examination is very important if you don't have any history or reports. So we will see if there is previous conjunctival scar medially or laterally, limbar or fornix based, recent scar. Because if you have a patient and he came to you after recent surgery for esotropia and she has exotropia, so you have to depend on clinical sense that maybe there is lost muscle from the medial rectus. Or all the scar and there is increasing gradually of exotropia after the old operation, and the anterior segment trauma the patient has. And the fundus examination also is very important, because maybe this patient has a scleral buccal for retinal detachment, and then he has multiple surgeries after that. Imaging, is it needed for every patient? No. We have to depend on your clinical examination, your slit lamp. Not every patient you have to send that child to do MRI or CT scanning. And the parents, of course, they are very worried about the child if you are sending him to do imaging. So what patient are you going to do imaging? Of course, if he has retinal detachment surgery before, we want to do, and we want to know where is the medial recti, lateral recti, or there is any complications from the previous surgery. If he has ENT surgery before and he has lost muscle or iatrogenic damage for the medial recti, and also if there is any trauma after the trauma, so we have to do the imaging for these cases. The imaging could be MRI, anterior segment OCT, or UBM, and the most of these is the anterior segment OCT. Now, consecutive exotropia could be due to immediate post-exotropia surgery or gradually due to previous ET operated patient. It could be due to slipped medial rectus muscle or lost medial rectus muscle or stretched medial rectus. They slip the medial rectus muscle. The medial rectus muscle is that attracts posteriorly within the muscle capsule. So you cannot find the scar, you cannot find the stretched scar, and you may not find the muscle itself. So the muscle receded back too much. So the lost muscle also, you can find there's no scar, no attachment to the muscle at all, or stretched scar. You find the muscle, but there is stretched scar. The stretched scar previously operated rectus muscle attached to the sclera by a segment of amorphous scar tissue rather than the tendon or a muscle. What is the management? For the slipped muscle or stretched scar, we have to do the force reduction test, as you all know. It is very important under the anesthesia to differentiate between the excessive resection of the antagonist or slipped muscle. Surgical management, you have to do general anesthesia. The topical anesthesia is not enough. Also, the local anesthesia is not enough. The general anesthesia is very important because you cannot anticipate what's happened before. So test the eye in position under the surgery. This is important. And do the spring reduction test. What is the difference between the spring reduction test and the force reduction test? The force reduction test, you are moving the eye in both sides. But the spring reduction test, just move the eye to one side and leave it, and to see if it's going to XT or ET. And also mobilize the conjunctiva, because this is a scarred conjunctiva due to previous surgery. So you have to detect where is your incision going to do. Is it limbal based, fornix based? And you have to touch the conjunctiva and to be away as far as you can from the scar. And also you have to mark the conjunctiva, because if you did also the limbal incision, you may lose your conjunctiva. And the conjunctiva in this situation is very, very important. And I also identify the stretched scar and measure and plan your decision. What are you going to do in this case? The lost muscle, there is no attachment, as we said, to the sclera, very large exotropic angle, very limited adduction. And to get the lost muscle, we have to do general anesthesia, do MRI to detect the medial rectus position, use the operating microscope, very important also, do large conjunctival incision or limbal incision, and retract the globe laterally by excision suture at the limbus, and do good exposure medially. And also trace the medial rectus capsule posterior in subtenons. Don't open the posterior fat compartment at all. And you may treat the muscle through its suture if it's recent. And also the oculocardiac reflex is very useful. And get the medial rectus and attach it to the sclera to the position that you want. In surgical management, the medial rectus advancement could be alone is enough for this case. Be always, it is very powerful. The medial rectus advancement and the resection is very powerful. 1 mm from the medial rectus advancement equals about to 4 prism diameters of XT. And your target should be not in the primary position, because there will be exotropic drift after doing the surgery. So your target should be 15 prism diameters of esotropia to avoid the exotropic drift post-operative. If you don't find the lost medial rectus, what to do? Recess the antagonistic muscle, the lateral rectus, ipsilateral or contralateral plus or minus Faden procedure, and do Hamilton test, Hamilton procedure for partial or complete. Conjunctivoplasty also, as we said, is very important for these cases. Remove the scar under the conjunctiva, suture them at the markings, and don't excise the conjunctiva. Don't sacrifice the conjunctiva. It's very important in this situation. And if you find a large scar under the conjunctiva, you have to remove as much as you can under the conjunctiva. Leave the conjunctiva free and very clean. The epithelium of the conjunctiva is very important, and we leave it very clean without any subconjunctival tissue. Again, this is the surgery. You have to test the conjunctiva. They have to test it by force reduction test to see where is the restriction, the medial rectus. And then I like to do the fornix incision. As you find that, I use the pinpoint hook. It's called the small finder or big finder. Also remove as much as the scar from over the muscle to see where are you going to do your sutures. Because the muscle now, if you advance it, it will be very tight, very powerful. So be sure for your sutures, where are you going to put. And this is your plan. Do the sutures horizontally and fixate the muscle well. And then do how much resection are you going to do. Just you remove maybe 2 mm and then advance the other. And then after that, you will cut the muscle and attach to the original insertion. And sometimes some surgeons make more advancement than the original insertion. And then, as we said, don't sacrifice the conjunctiva. You have to do very neat surgery for this patient because they are looking for the cosmetic result. Again, this is the patient, pre-operative and post-operative. There is good adduction in both eyes and in primary position. For the consecutive esotropia, the etiology mostly stretched the scar, maybe slipped the lateral rectus muscle in its capsule, and it's very easy to find the lateral rectus muscle, as you know, and overall over-recession of the lateral rectus muscle. Clinically, esotropia is angle at distance more than at near. This is divergence insufficiency. So if there is limited epiduction in one or both eyes, so you have to advance the lateral rectus. Or esotropia is more in the direction of action of the recessed muscle. There is incompetency. You have to also advance the lateral rectus. But if you find the esotropia more at near than at distance, so you have to deal with the medial rectus muscle. This consecutive limited epiduction means that esotropia at distance more than near. The management for this case is the immediate postoperative. If it's a small angle, so wait, don't hurry. For some days, wait. If you continue with large ET, do alternate patching for full time for 1 week or part time for 2 weeks, and examine the patient frequently, every 2 days, every 3 days, every 1 week. So, but don't lose the binocular fusion. It's very important for the intermittent exotropia. Follow the patient regularly and very frequent until, and also measure the stereopsis and be keen for this patient to not lose the binocular fusion. You may need hyperopic glasses if the patient has error of refraction. Post-operative consecutive alternate patching, cycloplegic refraction is very important after this surgery. And also, if V pattern esotropia, do small medial rectus recession with downshift. If esotropia more at distance, advance one or both lateral recti. And it's very easy to do for the lateral rectus, advancement more the medial rectus, of course. If esotropia more at near than at distance, do limited medial rectus recession with downshift. Recommendation, home message, we have what to do. Use non-absorbable sutures for large hangback medial rectus recession. Rescue and secure the medial rectus muscle suturing after dissecting the sheath. This is very important. Avoid sagging of the medial rectus muscle attachment to the sclera. Immediate post-operative check-up of squint angle with ocular motility assessment in adductions and divergence, very important. Don't lose the binocular fusion and stereopsis in intermittent exotropia surgery. Medial rectus advancement may be effective alone. 1 meter equals to 4 prism diopters of XT. Your target should be over correction 15 prism diopters of ET after exotropic, consecutive exotropia. Thank you very much. And I want to ask to thank Dr. Mona for invitation and the very nice sessions. Thank you very much.